Dear colleagues, ladies and gentlemen, welcome to the view of the Thoraxcenter for Radcliffe Cardiology. My name is Nicolas from Mieghem, and together with my friend and colleague Joost Daemen, we will review the late-breaking trials for the upcoming ESC 2023 meeting in Barcelona. Without further ado, let's start with the late-breaking trials on coronary revascularization, Joost.
Yeah, so welcome everybody. So there are 3 trials on coronary revascularization that at least stood out to us that we would like to discuss with you. One is the revived BCIS-2 trial. So this is a multi-center randomized controlled trial from the UK to evaluate whether PCI plus optimal medical therapy will reduce all-cause death and rehospitalizations for heart failure as compared to optimal medical therapy alone at 2 years in patients with ischemic cardiomyopathy. So this prospective trial will enroll 700 patients with stable ischemic cardiomyopathy with a definition of an ejection fraction below 35% and extensive coronary artery disease, and importantly also proven or demonstrable myocardial viability. To me, an interesting trial because most recent European guidelines on heart failure, as you may remember, provide a class 2A recommendation for revascularization in general in these patients in order to improve symptoms. However, a class 2B indication with respect to improving outcome, and then even suggest a preference for surgical revascularization. So in that perspective, I think this trial definitely will add to the body of evidence on the value of coronary revascularization in patients with ischemic cardiomyopathy, and has the potential to change the future guidelines.
I think it's a very interesting trial, but I'm a little bit well, not disappointed, but why so much emphasis on myocardial viability? Because we already have the STITCH trial with 10 years results that tells us that in patients with ischemic cardiomyopathy, if you have a poor LV, it doesn't matter whether there is viability, yes or no, in terms of long-term outcome. It does matter if you want to look for improvements in ejection fraction. Yeah. We know from STITCH that if there is viability, then your ejection fraction will improve, but it will not affect the outcome in terms of mortality. So that said, I think STITCH obviously was a surgical trial. That is why the guidelines also keep referring to CABG in the context of ischemic cardiomyopathy. And I do believe that this is a valuable trial, and I hope that PCI will prove beneficial in this setting. Obviously, it's also of interest to learn what the quality of the PCI is. Will they do coronary physiology? But more importantly, I believe, is there also invasive imaging involved to have optimal results?
Yeah, and the goal to go for complete revascularization. I think that is tremendously important. And with respect to your comment on viability, I totally agree. And that was, I think, also one of the key criticisms to STITCH, that a lot of the viability testing was done with SPECT and might have shown some balanced ischemia or negative findings that perhaps, were not really accurate.
Yeah, well, but in my practice at least, I also try to interpret the echo imaging. Obviously, when there is a very thin ventricle, then you may ask yourself whether it's worthwhile. But if there is only hypokinesia and you do see some muscle in the territory, in the affected territory, then I think it's a good idea to proceed with revascularization. So hopefully this becomes a positive study in favor of multivessel PCI in ischemic cardiomyopathy.
Yep, so then the second trial that we would like to highlight is, at least to me, one of the perhaps most interesting trials of the upcoming meeting, at least from an interventional perspective, and that is the FRAME-AMI trial. So this is a multi-center randomized controlled trial from South Korea to compare clinical outcomes following evavar-guided or angio-guided revascularization of non-infarct related arteries in patients presenting with acute myocardial infarction. So this randomized trial aims to enroll 1,300 STEMI patients with at least one non-infarct related artery with at least 50% stenosis, with a primary endpoint of death, repeat MI, or repeat revascularization at 2 years. As mentioned to me, this is one of the perhaps most interesting trials, specifically in light of the recently presented and published FLOWER-MI trial that addressed the same question, but was actually completely negative. I still believe in the concept. I do believe that physiological guidance of non-infarct related arteries could be beneficial. But the likelihood that this trial will be positive, at least to me, is based completely on the aggressiveness on complete revascularization. How aggressive will these operators be in order to treat everything that is above 50% in the angiographic arm? Because what we've learned is that the key benefit of FFR is in detecting those lesions that were visually perhaps not that severe, but were in fact physiologically positive, because those are the lesions that will make the difference in the event rates, and not the lesions with that are FFR positive and will get treated anyway.
So if you do not treat them, right?
If you do not treat them, yes.
So my gut feeling is also that this might become a negative trial for the reasons that you mentioned, and the cutoff for angiographically significant stenosis of 50%, that is maybe a little bit pushing it towards the too much, pushing it too far a little bit out. I think I would call a 70% angiographic stenosis more realistic. 50% is really trivial in my opinion. But I agree, the evidence to back up coronary physiology, hyperemic coronary physiology in non-culprit vessels in patients with STEMI is not that solid. So if that is also a negative study, well, yeah, we may question.
Yeah, absolutely. And then the final trial within this topic that we would like to cover is the pre-18 FFR trial. So not really a trial on coronary revascularization, but actually an imaging trial on PET-CT. So this is a prospective observational trial from the UK to assess whether what is the value of the PET tracer 18F sodium fluoride as a marker of coronary plaque vulnerability to detect culprit and non-culprit unstable coronary plaques in patients with the recent MI. So the trial is a prospective trial that will enroll 700 patients that will be enrolled within 3 weeks post-acute MI and angiographically proven multivessel coronary artery disease. This trial has a clinical primary endpoint, which is a composite of cardiac death, non-fatal MI, or unscheduled revasc at 2 years. The marker is not so novel. The marker has been validated and tested already in a Lancet study from, I think, 8 years ago. It's an interesting concept, but I'm not quite sure how these results should be interpreted, because of the fact that these scans will be obviously performed post-revascularization. So many of these potential unstable lesions will already have undergone either stenting or CABG. So yeah, I'm curious to learn the exact methods of this trial during the presentation at ESC, but I think something conceptually interesting that is worthwhile to look out for.
Yeah, definitely, I agree.
Good. Pharmacotherapy, several trials that we would like to highlight.
Yeah, the first one is Ascent, and Ascent, it might sound familiar. It was already published in the New England Journal 4 years ago. Basically, it is a huge trial, more than 15,000 patients with diabetes in the setting of primary prevention were randomized in a 2x2 design, either to aspirin or no aspirin, again in primary prevention, and then secondly also to the use of omega-3 fatty acids or no omega-3 fatty acids. In the New England, they already published the data on the omega-3 fatty acids that was negative. Now I assume we will hear about the effects of aspirin in primary prevention of patients with diabetes. We'll see. I don't have too high expectations. I'm not sure whether this will become a positive study. I think over the years we have seen a clear decay in the importance of aspirin. Maybe this trial will also fit in that series of studies. So let's see what it will bring. An interesting co-primary endpoint is the major bleedings, because we are used to saying to our patients, well, these very low doses of aspirin, it's not nothing, so if it doesn't work, at least it's not harmful. Well, maybe we will see a signal of harm. So I think this trial will add some evidence in favor or not in favor of aspirin in primary prevention in a high-risk patient population.
Yep, I agree. It's an interesting concept that has not been fully addressed specifically in these high-risk patients. So I think it will be interesting.
So I mentioned already the omega-3 fatty acids, and somehow I hope to find a study that somehow will be beneficial, because it is an attractive pathway, I believe, and it is a therapy with hardly any side effects. So if it might be beneficial, I think it would be accepted by the community, but it's so damn difficult to find a positive study. Well, there is REDUCE-IT that will be presented by the inevitable Deepak Bhatt, because Dr. Bhatt, he is presenting late breakers at every ACC and ESC, so also in 2022, and now he will present REDUCE-IT. And it is a randomized controlled trial enrolling more than 8,000 patients over a time period of 7 years and more than 400 sites. So it's a huge study. Patients are followed up for at least 6 years, and the primary endpoint is any serious event. And patients are randomized to either normal therapy, including statins for patients with at high risk with mixed dyslipidemia, but then they are randomized to either icosapent ethyl or placebo. And what is this icosapent ethyl? This is a purified ethyl ester of one of the omega-3 fatty acids. So this is the next shot at a positive study for the omega-3 fatty acids. I'm rooting for it, so let's see what happens at the ESC.
I have nothing to add to that.
Okay, let's go to the PHYSIC AMI.
Yeah, so perhaps a bit more common ground concept is the PHYSIC MI. So this is a multi-center randomized controlled placebo double-blind dose-finding study, so phase 2 trial actually, to evaluate the safety and efficacy of a novel factor 11A inhibiting agent called asundexian in patients following acute MI. So this is a trial that will enroll 1,592 patients within a 5 days post-MI who will be randomized in a quadruple fashion to either 3 doses of this novel factor 11A inhibitor or placebo on top of dual antiplatelet therapy being aspirin and clopidogrel. The trial has 2 co-primary endpoints. One is an ischemic one, being CV death, MI, or stent thrombosis within 1 year. And the second co-primary is obviously bleeding, being BARC type 2 305 bleeding. I think interesting, the trial makes me remember a little bit of the period when we saw Atlas 15 years ago with rivaroxaban on top of aspirin and clopidogrel, also showing potential benefit in terms of ischemic endpoints, but for sure a higher risk of bleeding, in a drug that finally never found its way into routine practice for the treatment of patients post-MI. I don't know whether the same fate will happen to this agent, but it's again another pathway that is being explored with this novel drug. We'll see.
Yeah, but without knowing the granularity of this study, this is 2022. Why are we talking about DAPT with aspirin and clopidogrel after an AMI? I think that is a little bit old school. I think we are beyond that, at least in patients who do not need oral anticoagulant drugs. So that is a little bit a limitation to me, especially if we want to extrapolate it in the short term to our current practice, because we are now using ticagrelor or prasugrel in combination with aspirin, and then by doing so we're also looking at schemes to reduce DAPT duration. So instead of adding more anticoagulants or antithrombotic therapies to DAPT, we are thinking about moving towards single antiplatelet therapy. So for me, I'm not so intrigued by the concept at this point, but we'll see what happens.
Yeah, I agree. I have mixed feelings. I think at present we are more looking into how to downgrade antithrombotic therapy. That is a certainty now with COMPARE-STEMI1 upcoming, etc. There's a lot of trials looking into the value of the monotherapy post-ACS. Most of these most recent trials demonstrated similar ischemic risk rates with a reduction in bleeding. But on the other hand, I mean, there's still a substantial risk of ischemic events in patients post-MI. And there hasn't been any novel agent that has been consistently shown to be safe, but also substantially reduce ischemic events in those high-risk patients. So who knows? I'm not too negative, but yeah, we'll see. Structural heart, 2 trials that we wanted to highlight.
Yeah, one of them is the CoAPT continued access study. Well, we're all familiar with the success of the CoAPT study that was presented a couple of years ago at TCT following the MITRA-FR study on the value of MitraClip in patients with functional MR in combination with LV dysfunction. CoAPT was a positive study, so patients were doing better at 2 years in terms of the combined endpoint of mortality and rehospitalizations. Well, now we're going to see how MitraClip is behaving in the continued access study following CoAPT. Well, there are several unknowns for the presentation. What is going to be presented? Is it specifically and only the continued access population, or are the continued access patients on top of the patients in the randomized controlled CoAPT trial? But I do believe that we will see a larger patient population, obviously, and so hopefully the study endpoints and the signals that we see in terms of outcome will be more robust because of the higher patient population. So I feel that this is a relevant add-on to CoAPT. At the same time, I also want to caution on the over-interpretation of CoAPT, because we had stringent inclusion-exclusion criteria. There was a screening committee that screened a lot of patients out of the study. Yeah. So the reproducibility and the applicability to everyday practice is a little bit in doubt, in my opinion. But then again, that is maybe also a good argument in favor of a continued access. Hopefully this steering committee is not involved so that it becomes more reflective of common practice.
I think it will be a tremendously important data that will provide definitely more heterogeneity in the treatment effect than as was shown with CoAPT. And that might be very positive, but could also point in a direction with let's say efficacy figures that are perhaps less pronounced than in the randomized arm. So we'll see.
Yeah. Another trial that we wanted to highlight is data derived from the National Echo Database of Australia. A couple of years ago, that same database was used to illustrate the importance of moderate aortic stenosis. So that study back then illustrated that moderate aortic stenosis basically in the long run had the same outcome as or similar mortality rates, almost similar mortality rates in patients with severe aortic stenosis. So that already was a little bit undermining the paradigm of moderate aortic stenosis being harmless. Obviously, we are heavily involved with the concept of treating moderate aortic stenosis in the context of patients with depressed LV function in TAVR Unload, and there is now also the PROGRESS trial, where we are moving on from the ejection fractions and go to the cardiac damage model. Well, now the same echo database of Australia is being used to see whether artificial intelligence can be helpful in identifying the patients with aortic stenosis who are also at risk for events. So you can expect hundreds of thousands of patients, so multiple hundreds of thousands of patients, and then they will implement an artificial intelligence program on that data set. And what is interesting is that this program will specifically not look at LVOT measurements. And obviously we are all familiar with the limitations and the restrictions of echocardiography, and some of these limitations are related to the difficulties related to LVOT dimensions and also LVOT velocities. So once you make a mistake there, then the entire measurement of your valve areas will be jeopardized. So I think if this study can show that by artificial intelligence you don't need LVOT to identify the patients with severe aortic stenosis who will get the events down the stretch, I think that is progress, and I think that also really fits in the time we're living, 2022. Artificial intelligence, it remains a hot topic in digital health and in medicine in general.
Yep. Yeah, I agree. I think the size of this program is enormous, and that I think adds to the validation of all these AI algorithms that are typically being tested in 200-300 patients, and then might conceptually point in a direction, but do not have the power to impact any of our practices.
This is next level.
It's next level. Yeah. But yet, I haven't seen that many AI studies that really came up with findings and clear cutoffs that we're currently using. So I think it's work in progress, and this is probably a very good example on how these data can be used.
But the interesting aspect of this study will be the uncoupling from the LVOT.
Exactly.
Right? And that is quite intriguing.
Yeah.
Okay, maybe we wrap up with some hypertension.
Yep, as usual, we picked one trial on at least one of my favorite topics is hypertension and renal denervation, and that's the PHYSIC trial. So PHYSIC, I will try to explain to you. It's a little bit of an uncommon concept. So with a double-blind, randomized, repeated crossover design, this PHYSIC trial aims to investigate if there's a consistent between patient variation in blood pressure response to common blood pressure lowering agents. So the trial will enroll 300 patients that will have mild hypertension and will be treated with 4 blood pressure lowering drugs, being amlodipine, lisinopril, hydrochlorothiazide, and candesartan in monotherapy, with 2 of the drugs being repeated for each patient. So this trial will look into the predictors of the effect of each of the individual drugs in all these individual patients in terms of blood pressure lowering efficacy. The trial will look into side effects generated by each of these 4 different classes of antihypertensive drugs, and will also provide a biomarker panel for each of these patients in order to be able to, by doing these biomarkers, perhaps identify potential triggers that could help us in the future to select certain types of patients that either do respond or do not respond to each of these 4 classes of antihypertensive drugs, or might be more prone to side effects, which then is the common predictor of having non-compliance, which is at present, as we know, one of the key predictors of poor blood pressure control. So a very interesting concept in a trial with a unconventional design that to me will be of interest, and if positive and if some clear findings will emerge, these data could really help us to better tailor antihypertensive therapy in those patients.
But don't you think that there is a sample size issue here? 300 patients to address all these questions?
Yes, but all these patients will get these 4 agents during a certain period of time. So you will get, I think, a relative representative sample of side effects and of common side effects. Obviously not the side effects that will emerge in 1 out of 1,000 patients. But that already, I think, by itself is already interesting.
But then again, to see the differences between the several different drugs in only 300 patients?
I agree. The sample is small. The concept of interest, and you might be right that this trial comes up with several hypotheses that will then be further tested in a larger trial. Could well be.
So, and then the elephant in the room, where is the renal denervation then?
So, that's a good point. No renal denervation, big trial at ESC, but what I can introduce already is that at TCT, the final results of the Radiance 2 trial on ultrasound renal denervation will be presented. So that is something to be covered within one of our upcoming previews. Yeah. But thus far, our preview for ESC 2022.
This is it for the preview of ESC 2022. Joost and myself, we will attend the ESC meeting in Barcelona. So expect from us a wrap-up the week after ESC. Thank you very much for attending.
Thank
you
you
later.
for watching. Bye-bye.
Bye.